So this will finish up airway management. We'll call this part 3. Types of airway obstruction. So if we see somebody who's standing, they're looking at us, whatever, but they appear to be in distress. And probably the most common thing people do, if I'm sitting in a restaurant, I'm eating, and then all of a sudden I can't breathe, I'm going to panic. I'm going to stand up. I may even try to move around, just not being right because not as much oxygen is getting to my brain. Think of it like when you were a kid and you went swimming and somebody took your head and dunked you underwater. You could look up, you could see the surface of the air, but still you started panicking. And you had a little bit of trust that your older brother or sister wasn't going to kill you, but you didn't know that. So that's how people feel when they can't breathe. So when you look at them and you tell them, are you choking, they're going to be quite frantic. And I don't know why, but it's a reactionary thing is we grab our throat. So that's what we call the universal distress signal for choking. And I'm going to ask them, are you choking? Can you cough or talk? We used to ask them, can you talk? And then found out some people were actually deaf mute. They couldn't speak anyway. And then we started doing interventions when there was really nothing wrong. If they can cough forcefully, that's the best way to remove that obstruction. Just stay with them. And women, we tend to want to leave the room, go into the restroom, lock the door. Unfortunately, that partial airway obstruction may become a complete airway obstruction, and now we're behind a locked door. So not a good thing. You have my permission, guys, to follow women into the restroom and say, hey, I'm just here to see how you do, just in case. Yeah, that would be fun, right? Mild airway obstruction, they're going to cough, they're going to be able to speak, just like when you choke on a little bit of fluid. So encourage them to cough, stay with them, and sometimes people have partial airway obstructions that they can't clear, especially kids. Kids less than the age of 8 can't swallow a quarter. It just won't go between the passageways in their throat, even down the esophagus. So it can sit there, hopefully upright, and they can breathe around it. If it turns flat, then we've got a problem, so they may need to be transported. But a severe airway obstruction, they're not able to cough, they're not able to talk, they're not able to move air in and out at all. Or they have really poor air exchange, they're barely moving air, wimpy cough, then you need to intervene. They're going to lose consciousness in just 3 to 4 minutes. So treatment involves abdominal thrust. Anyone over the age of 1, so adult, child, if they're conscious, you stand behind them, place your finger at the navel, and then place a fist with the thumb side in directly above that navel. And you're going to do that. We like to do it 5 times and then reassess. Same thing on a child. And this is a child that's unresponsive. We start CPR. We'll come back to that. But like this. So right above the navel, in that soft spot below the ribs, so kind of how the ribs make a triangle, and you're going to be right there in the middle of it with that thumb side of your fist in. You're going to pull upwards up to 5 times. It means if it comes flying out on the second thrust, don't keep thrusting. Stop then, you've seen a change, and ask them how they're doing. But the reason we say 5 is, what if you just kept going and they're trying to tell you, I'm okay, I'm okay. And about the time you do, you thrust and you're all excited and it doesn't come out. Anytime somebody becomes unresponsive, we can't pass airway to do anything else other than circulate blood. Now here's the neat thing. There's enough residual oxygen in the blood that if I circulate that to the brain, I can keep the brain oxygenated for a longer period of time. And then when help gets there, they take over. So no matter if it's a child or an infant, once they become unresponsive, we start CPR. And airway obstruction on the kid, though, they have very large abdomens. Not because they're chubby, but because they have a very large liver, a very large spleen that they have to grow into. And if you did abdominal thrust, you could actually rupture those organs. The other thing with kids is we don't do blind finger sweeps. Like adults, you might fish around in there. The danger with the kids is you're going to touch it and push it down further. So pretty much don't put your fingers in kids' mouths. If they become unresponsive, then you start CPR. So that's what back slaps look like. I like this picture because they're supporting the head, they're supporting the trunk, and the head's down a little bit lower than the trunk. They kind of have them angled with the airway open. If the airway's closed, it's not going to come out. You deliver up to 5 back slaps. That means if it comes out on the second time, don't hit them 3 more times. Mamas get mad. I got to tell you, in all the years of doing this, I've never hit a kid more than twice. And I've always hit them twice. I think it came out on the first hit, but I was already locked and loaded, and bam. Best sound in the world is a crying baby, because that's an open airway. unless it's following me around at Walmart. Then it's not the best sound in the world. As promised, here's the picture of the jaw thrust. So the only thing I don't like about this picture is the guy's probably on a pillow. I don't like that his head's flexed a little bit forward, but it was the best one that I could find that shows that you use the cheekbones, put your thumbs there, and you kind of pry. Just like snapping your fingers, like you kind of pry, lifting the angle of the jaw up against the cheekbones. Of course, if you push down and the cheekbones are fractured, stop doing that. Find something else to lift that jaw by. And the other thing I like about this picture is she's holding the head in a neutral inline position. And this person's at the head. If you're at the head, that's where the captain's seat is in the ambulance. You own the airway. That is your job, airway and breathing. Let's talk a little bit about oxygen. So people who are breathing adequately, normal rate, normal depth, volume's good, nice and regular, not making a lot of noises. But for whatever reason, maybe their pulse oximeter shows that their blood oxygen level is low, or maybe they're a little blue, or some indication that they just need a little bit of this medication. Tanks come in variety of sizes. Their size D or E are considered portables, and then your H's or M's are your big oxygen tanks that are kept on the ambulance. Some people will carry medical oxygen concentrators, so you can have more with liquid versus gas. So sometimes you'll see people having their own portable oxygen. Full tank is 2,000 psi. So when you look at it, it says 2,200. It doesn't mean it's going to explode. So 2,000 is full. Luckily, you got a little bit more. But let's talk about empty for a second. We don't have to wait till it gets down to 0. So we're going to change that out, and I'll share that with you in just a little bit. So on the tank itself, you have the tank with the yoke. This is all the tank, and then you're going to put the regulator over the yoke. Be real careful with these. If that yoke breaks, that stem, that's kind of a weak place in the oxygen tank, and you think about 2,000 pounds per square inch. Can you imagine a cow, a really large cow, standing on one foot, stepping on your foot? That's what 2,000 psi, that's how much pressure it is. So think about that. We don't have to wait till the tank's empty. You can see this regulator here, it's at 1,000. See that black needle? Shows you in the green where it's full, and it shows you in the red where it's time to fill it. So when it gets down to 500, we take it out of service and we replace it with another tank. There's something called a safe residual. Back in the day, we had to know how to calculate how long a tank would last. And just it kind of depends on how many liters per minute that you're running it. But so picture yourself in a helicopter going from an island to another island. So you're over water. You don't want to have just enough fuel to get there. You want to have a safe residual. So we always subtracted 250 or 200. Actually, it's 200. I don't know why I wrote 250. It's 200 is your safe residual to be able to have a little bit left over that you wouldn't run out like a helicopter running out of fuel over water. Apologize for that. It is 200. Your pressure regulator fits over the yoke, and it's got a pin index. So it's got two little pins that fit in the two little pins on that side so you can't mess up. One thing we like to do before we put a regulator on is crack the cylinder a little bit, especially if it's been sitting, to clear out any debris so the debris doesn't go into your regulator and then damage your regulator. Typically, regulators can run 2 to 15. We'll stay with what your book says. I mean, it can go down to 1, but what's the big deal about 1 liter of oxygen? And there's usually a gasket or a little washer that helps keep a good tight seal on there. So the adjuncts that we can use. Nasal cannulas and face masks. Nasal cannulas are designed, the little prongs go into the nostrils. They need to be nose breathers with clear noses for this to happen. Whereas if somebody needs a lot more oxygen, or they tend to be mouth breathers, then a non-rebreathing mask would be common. So some safety things about oxygen. It is, they're not flammable, but they support combustion. So we don't want to have anybody that's smoking around there or have anything flammable that could create a flame because it will accelerate that. Oily substances sometimes do that too. There's been a number of stories where people are checking the oxygen cylinder and they keep it next to something that's oily, and then flames come out of the port. So be real careful with it. And it's a compressed gas cylinder, so if it falls over and that yoke breaks, it'll just spin around. I mean, people have had scuba diving tanks, break inside pools, and it puts a hole in the cement pool wall. So be careful with these. Always hang on to them when they're standing, or lay them over, or put them in some device that keeps them from falling over. So this is most of them now have a little toggle at the top, because if you have just that little device that you need a wrench for, you know, if you lose the wrench, you can't use your teeth, you can't use anything to open that. So most of them come with their own toggles, or make sure the wrench is quite handy, and there's a lot of them around. Lefty-loosey, righty-tighty. So left 2 turns will turn it on. It'll keep turning, but that's all you need. So you don't need to turn it any more than that. Look at the gauge to see how much, what the volume is, a PSI is, and then adjust your liter flow to whatever you need it to be. Make sure whatever you're putting on the patient that you're running the oxygen before you put that on there. You put a mask on them and there's no oxygen, it can actually suffocate them. This is what a nasal cannula looks like. It delivers 2 to 6 liters per minute. Well, yeah, it can deliver 1, but what good is that? Your book says 35 to 50%. And just know that it's low volume, low flow, low volume. Maximum is 6. Anything more than that just, you know, dries out their nares, and you can hear it coming out of their nostrils. They can't breathe it in fast enough. Now here's something we always learned. Your book was the first one that I saw this. Remember that 20% room air oxygen concentration? Add 4% for every liter per minute that you run your oxygen. So an example of this would be you run the oxygen at 4 liters per minute. 2 to 4 is quite common. 20% plus 4 times 4 is 16, so it would be 30. So you're giving them about 36% oxygen concentration. Again, if they're nose breathers, if their nostrils clear, that kind of thing. Just kind of a close formula. Non-rebreathing mask, it has a reservoir on it, so we'll fill that reservoir first. It also has, and this one is a true non-rebreather. See these little flappy guys to the side? Because there's holes right here. And these are flutter valves. A true non-rebreather has 2 flutter valves. Now your service is probably like most. We buy the partial non-rebreather, so it only has 1 flutter valve. Why is that good? If we run out of oxygen, we will know it, because that reservoir, that little sac, that bag below that rests on the chest will be empty. It's not filling with oxygen. Well, if we don't catch that fast enough and we have 2 flutter valves, we're suffocating our patient. If we have 1 flutter valve, then they have tiny holes that they're breathing air through. Non-rebreathing mask with a good fit can get you about 90% oxygen. So if somebody is really cyanotic and needs oxygen, this is what you would use. And it doesn't matter if they're mouth breathers or nose breathers. Higher concentration of oxygen, higher flow rates, so people like this that need higher concentrations. There are some hazards to this, so you're going to get to practice in class. Respect the oxygen cylinder. If you have instructors like I know you do, you set that tank up on a table and walk away, and somebody's going to freak out, because if that thing falls, there could potentially be some damage and also some injuries. Pulse oximetry, we talked about this in our vital signs. It's always good to repeat things. It measures the saturated oxygen in red blood cells. So it's designed to be put on a fingertip or a toe or an ear or something like that. And it measures not only the percentage of oxygen right here, but also the heart rate. And normal for a person is 95 to 100. Now here's the danger. If you give somebody 15 liters of oxygen, your pulse oximeter is going to stop at 100. So we don't know if they're 108 or whatever. And oxygen and carbon dioxide sit in the body like a teeter-totter. When one's high, the other one's low. So we don't want the oxygen to get too high and dropping the carbon dioxide. So anyone 94% or below may need a little supplemental oxygen. And normal we usually say is 99, because you don't really know what 100 is. It has certain limitations. So if somebody's got nail polish or dirty fingers, well, here's the trick. Don't put it flat on the finger, turn it sideways. It measures through the skin, not so much the nail. If somebody's really cold, the arms and legs are going to constrict the blood and shunt it more to the core, so you may not see a lot of perfusion, a lot of blood flow to those arms and legs. If they've lost a lot of blood, that's going to factor in, or if they have carbon monoxide poisoning. So here's a neat thing about carbon monoxide, if there is such a thing, is it displaces the red blood cell's ability to carry oxygen, but now carries carbon monoxide. The skin stays red, so does the blood. So you can actually have a really good reading on a pulse oximetry but your what they call carboxyhemoglobin level is high. Normal carboxyhemoglobin level is 0. If you're a smoker, it may be 2 or 3 or 4. Now, some services are lucky enough on their automated blood pressure machine to have a pulse oximeter that every 7 seconds checks the carbon monoxide level in a patient. That's pretty cool if you have that. Rescue breathing for people with stomas. So people that have had throat cancer may have a partial or total laryngectomy, removal of their larynx, and they have a stoma in place of that. So I changed a couple of things here because it said if there's a breathing tube, remove the tube. No, if there's a breathing tube, just take the mask off of your BVM and attach it to there, and you've got airway. It's a really neat way to do it. I know this is a cadaver, but it was a good picture. The other thing I like is that's a little mask on there. So you can connect that tube, the valve right to their tube, or you can take an infant mask, if they don't have that connection, put the infant mask over the neck, and then use an adult-sized bag, because you still want the volume to be good. It's a little harder to get a seal, but it's a lot better than doing mouth to stoma. Because the next slide says if there's no tube, you can place your mouth directly over the stoma and do the same thing as you would do mouth to mouth. Yeah, I don't think I do that either. Sometimes there's thick secretions coming out of the neck that you don't want to have in your mouth. So that infant mask attached to an adult bag, ventilate. If they have a partial laryngectomy, then you're going to notice the chest doesn't rise. You may have to have somebody seal the mouth and nose because some of the air is leaking out those airways. If we ventilate too fast or too forcefully or too much, we can cause the air to go down into the lungs and also the esophagus. Well, the lungs breathe air in and exhale out. The lungs do not. The stomach does not. It traps the air. And pretty soon you'll look over and say, hey, why didn't our 60-year-old male patient get pregnant? Well, that's called gastric distension. So you want to make sure you have good airway positioning. You want ventilate just enough, and you don't blow up their abdomen to where they have excessive air in there. Everything that you put in has to come out, and it's going to bring friends with it. So everything they've eaten in the last 6 hours is going to come out. So be real careful with this. Some people will say once they get distended like this, yes, it affects the heart. Yes, it puts pressure on the lungs. Just like that Thanksgiving meal and you're so stuffed, you're like, man, it's hard to breathe. But if you push on the abdomen, if you do anything to relieve that distension, they're going to vomit. So let's keep everything down there and just do better with airway positioning. Dental appliances like dentures, if they're fitting well in there, just leave them there. You got a good seal. If they're loose fitting, they can cause a problem. Partial dentures or whatever can go down into the airway. So remove them, put them in a safe place, not your pocket. Airway management in a vehicle. So they're sitting up. Wow, they're sitting up and I have to do airway management. I don't have this nice little luxury of them laying down and I'm at their head and all this kind of stuff. So when we look at that, let me go ahead and show you the picture. I like this picture. I don't love this picture because he's from the side. He's actually cupping his hand under the chin. He doesn't have real good support. But for a quick, airway positioning, it's not bad. You see him move him into the neutral inline position. If I were in the back seat, I could do the same thing and keep my hand out from under his chin. So we can hold cervical spinal stabilization as well as keeping that airway open. Airway management in a vehicle has a lot of different advantages. From the side, you don't have to enter the vehicle, but if it's stabilized in the back seat, it's going to be preferable not only for the patient but also for yourself. With a finger, you can check the carotid pulse, you can check breathing, so you're communicating, hey, I got C-spine, I'm talking to the person, he's got a good strong pulse, he's breathing adequately, and everybody kind of goes, okay, whew, ABCs are secure. Summary. Main purpose of the respiratory system is to bring in oxygen and remove carbon dioxide because red blood cells carry oxygen to all parts of the body. When a person experiences respiratory arrest, we're going to start by checking level of responsiveness, check for circulation, and if there is a pulse, then we'll come back to airway and breathing. We've learned at least the knowledge of how to open an airway with head tilt chin lift or jaw thrust maneuver, how to look for fluids, and if we see that, how to section that out. We're also going to maintain an open airway by putting in either an oral or nasal airway. And then steps for removing a foreign body object from adult, child, or an infant. We've talked about how to use oxygen and how to measure how well somebody's doing with pulse oximetry. Pulse oximetry, put it on before you put oxygen, see what the normal room air concentration is, and then with oxygen, see if you see an improvement. Little review. After opening the airway of a patient who has a pulse but is unconscious, you should perform a blind finger sweep. Blind finger sweep is always out. Immediately attempt to insert an OPA, an oral pharyngeal airway. Well, let's do something else first. Check for secretions, foreign bodies, or dentures. I like that. Perform CPR. We didn't say anything about having a pulse or not, so it is C. We're going to look in the mouth. You should place a patient in the recovery position. Remember, that was on their side to prevent the patient from going into respiratory arrest. It's not really going to prevent that. Allow secretions to drain out of the mouth. I like that one. But I'm going to keep on going in case there's a better one. Protect the patient's spine from injury. That doesn't really protect their spine. Facilitate the administration of supplemental oxygen. That's actually going to make it harder. The correct answer is B. Let the fluids drain out. Pulse oximetry is used to assess the amount of oxygen saturated in the red blood cells. Couldn't say it better myself. Let's keep reading. Provide supplemental oxygen? Nope. Assess how much oxygen the patient requires. Wow, that's kind of a good answer, right? Because what if it was 92? I would know he needs oxygen, but not really how much. So that one's out. Eliminate carbon dioxide from the bloodstream? No. Best answer there was A. And this wraps up Chapter 6, Airway Management.